Unit 1.5, Integrating Knowledge to Think Like a Clinician. In this class, we will integrate everything you already know about anatomy and physiology to learn how to think like a physician. It's not just about recalling structures or functions, but about understanding how those pieces come together when facing a real patient. Clinical reasoning is the bridge between what you know and what you do. Clinical reasoning consists of connecting what you already know with what you observe. It's a process that combines observation, analysis, and critical thinking. Every time you hear a symptom or see a sign, your mind activates all your previous knowledge to make sense of it. Behind every symptom, there is an anatomical and physiological story. For example, when a patient presents with dyspnea, it's not just shortness of breath. There is a change in ventilation, gas exchange, or muscle function. Your job as a clinician is to find out which part of the system is altered and why. When reasoning clinically, we use two ways of thinking. System 1 is fast and intuitive, based on recognized patterns. For example, epigastric pain migrating to the right lower quadrant makes you think of appendicitis. System 2 is slower and more analytical, useful when the case doesn't fit the pattern or is more complex. Both systems work together, and learning to balance them is an essential clinical skill. Now let's look at the sequence of clinical reasoning, the path you follow to reach diagnosis and treatment. Everything starts with data collection, followed by hypothesis generation, the selection of studies to test those hypotheses, the final diagnosis, and finally the therapeutic decision. These steps form a spiral that repeats and adjusts as new information emerges. The first step is data collection. This includes medical history, initial observation, vital signs, and physical examination. From this moment, your reasoning begins. You observe, interpret, and connect. The best clinicians are those who know how to listen and observe attentively. With the gathered information, you build your diagnostic hypotheses. At this point, you activate your prior knowledge and think, which diseases could explain these symptoms? It's not about having an immediate answer, but about constructing logical possibilities that you'll later test. Next, you select the studies that will help you confirm or rule out your hypotheses. It's not about ordering everything, but choosing what makes sense based on your prior reasoning. The key is to justify each study. Why do I need it? What do I expect to find? With the results, you analyze the data, compare evidence, and reach your final diagnosis. But it's not only about naming the disease. It's about understanding its pathophysiology, origin, and progression. Thus, the diagnosis becomes a synthesis of your entire thought process. Finally, you make a therapeutic decision. Here you apply your clinical judgment. You choose the safest and most effective treatment, consider the patient's conditions, and plan follow-up. Clinical reasoning doesn't end with the diagnosis. It concludes with the medical action that seeks to improve the patient's health. Let's apply the sequence with an example. A young patient presents with diffuse abdominal pain, fever, and nausea. First, you collect data from the history and examination so you can formulate hypotheses like appendicitis, gastroenteritis, or biliary colic. Then you select studies like CBC, urinalysis, or an ultrasound. With the results, you can integrate a diagnosis and make the corresponding therapeutic decision. This process, though it seems simple, is the foundation of clinical thinking. Over time, experience gives you intuition, but reflection gives you understanding. It's not enough to see many cases. You must think about what you did, what worked, and what you learned. That reflection transforms experience into clinical knowledge. All physicians make reasoning errors, like clinging to the first idea, closing the case too early, or looking only for data that confirm their beliefs. Recognizing these biases is part of learning. Thinking clinically doesn't mean always being right. It means learning to doubt wisely. Clinical reasoning doesn't begin with diagnosis, but with observation. From the moment the patient enters the room, you are already collecting data. Their posture, expression, or breathing. Observing carefully is the first step toward reasoning accurately. Remember this idea. You can't reason what you don't understand. To interpret symptoms, you need to understand the anatomical and physiological mechanisms behind them. That's why we continue studying the fundamentals. The goal is not to have all the answers, but to learn to think like a physician. Practice with curiosity, question, justify your decisions, and review your mistakes. This is how clinical judgment is built, step by step, patient by patient. Clinical reasoning means thinking with purpose. Thinking not only to solve a case, but to understand the patient and act meaningfully. Each piece of data, each symptom, and each decision are all part of one thread, your clinical thinking in action.